I want to welcome everyone to what I think is going to be a really fascinating presentation. The theme, of course, is to get the kind of the view from the perspective of the healthcare providers who are so centrally involved in the pandemic, and with such a demand, played such demanding roles. And I think still do to a considerable extent. So we are going to begin with Joanne Levin, who continues to serve, I believe, as the chairperson of the Northampton Board of Health. And she is and simultaneously practices as an infectious disease physician, and the medical director of infection prevention at Cooley Dickinson Hospital. John Liebman is a nurse practitioner at Hilltown Community Health Center. Even though it's Hilltown, he is located, will be speaking to us from Amherst. He has served as the medical director of the health centers, clinics in Amherst, Worthington, and Huntington, and he continues to serve on the team that's responsible for the COVID response throughout the pandemic. So Joanne is going to start, give us the overview, and then we'll move on to John. And I'm sure they're going to want to have some interchange as things evolve. Go ahead.
Thank you, and nice to see all of you. It's hard to know where to begin. And jump in anytime, ask questions. John, you can jump in anytime. So just to start is in thinking about when the pandemic started, just to say that I don't remember a lot of it. And I think it's probably because there was so much anxiety around that time that it's really, it affects your memory. And like my memory of events, it's like COVID or it's pre-COVID seems so long ago, like time like is weird. Like, well, anyway, I'll start somewhere around February. There was one day I was following the news a lot about the disease that was, anybody else mute, please? Is that coming from me? Oh, that's okay. I remember the day when I realized that COVID, or was called coronavirus then, was really going to be an issue. I've been following the news, you know, cases have been found in Seattle and cases in Boston, and everyone was related to travel until one day, I think it was outside of Seattle, a patient was found that had not traveled. And that was the day I called the medical director of Cooley. I said, we've got a problem, start planning.
Well,
and of course they had been thinking about planning ahead of that, but it was like, now it's really time. And so what happened after that, and you know, things sort of shut down. So that was the end of April, at the end of February, and things really shut down mid to late March. And my role at the hospital, mainly I was a clinician seeing patients in the hospital and in the office, but I had a small job as infection prevention medical director. And what that means is, it's my job with the people I work with. I have a fabulous nurse that I work with named Linda Riley. And it's our job to sort of make policies and educate folks who work at the hospital to try to decrease the chance that people will get an infection of some kind while they're at the hospital for something else. And we've always been involved in PPE, and most people didn't know what that was. Now everybody knows what that is. And we became the sort of PPE queens. And what was so crazy at that time is that we would try to keep up to date on the information. Now, I don't know if you guys remember, but like the CDC was putting out different information every day. And I would try to keep the medical staff and the nursing staff educated about what's today's the latest, right? And I'd start a memo in the morning and have meetings and this and that. And by the end of the day, my memo was out of date. It was so hard to keep up with information. So my boss came into me, very early on and said, normally you work about 6 hours a week at the hospital. Could you work 40 or more starting now? And I said, okay. So I did that for like 6 months. That wasn't exactly the plan, but I was glad to do it. This is what infectious disease providers live for: pandemics and epidemics. And I started my career with AIDS. I did a lot of education around Ebola. We never saw an Ebola case. I did a lot of education around measles. Like, this is what I do. But never, obviously, have I been involved in a pandemic like this. So what was interesting for me, really interesting, is that from a very small administrative job, I became sort of a full-time administrative job, and the hospital set up an incident command center. And so every morning, all the hospital leaders, and we had people in key positions, we would all gather. Actually, we would actually gather in a room, a large room with masks on, eventually. And we would listen. So now, Cooley is part of the Mass General system. And so Mass General sort of emergency planning would be up on the latest. We'd hear a call and hear sort of their recommendations on what's the latest PPE, what are the things we have to think about, how are we going to do this and that. And that was really interesting. I've never been involved in something like that before. There were a couple of administrative people whose jobs were to keep the communication straight. They'd have a chalkboard, like, okay, who's doing this? What's everybody's phone number? How do we contact this person? How does one know that the other one is what everyone else is doing? It was really very, very interesting. And I was really, it was really interesting to be involved in that. And I think it worked really, really well. I'll have to say that being part of the MGB system, we are directly under MGH, and we're part of this big MGB system, which involves Brigham and Women's and a bunch of other hospitals. It was so great that we had their support, because they really are leaders in the field, and they have a very close relationship with DPH, Department of Public Health in Boston. And so they were really on the cutting edge of knowing where we're going and what was happening. And so to have them involved was really so helpful, rather than me having to try to go read the CDC information and try to figure out what that means and try to keep up on that. It was really so helpful. The other way being part of MGB was really helpful for us is that they had an enormous stockpile of PPE. There were a lot of hospitals we would see in the news about hospitals in New York where people are using garbage bags instead of gowns. And we did not have that problem ever, because we had this huge system, and one of their specialties is disaster planning. And so they had this enormous stockpile of stuff. So it was really very interesting, but I have to say, I don't remember a lot of the details because every day was just so intense. And another interesting thing is that what we had to do, what our work was, not only informing everyone in the hospital system as well as in the community, but was changing every single system in the hospital. How people come to the hospital, you have to give them a mask. You have to ask them if they have COVID symptoms. Who's going to sit at the door and do that? Can they go to the lab? Can they get an X-ray? How do we do testing, right? No one wanted to do indoor testing. How do we do testing? And who was allowed to be tested in the beginning? The Department of Public Health limited who could be tested, and every day they would change the rules. So I was the one who had to okay, let's figure out what that means for us. And how do we do that? So it was really, really interesting that way. And there was a lot of teamwork involved, and it was great. We have wonderful people at Cooley, and I was, got to know people well because we worked so closely, and everyone was really supportive of each other. It worked really well. But I'll say that my experience, when people, talk about how they spent the pandemic home cleaning their houses because they weren't going to work or whatever, my experience was so different from that. It was only 6 months later where I actually got to take a breath, and sort of, clean my house. And my husband's a cardiologist. He's on the line, I think. And I remember in April when things really shut down and people stopped going to the doctor, doctor's offices were all shut down. people who didn't have COVID really didn't want to go to the hospital. They didn't want to have routine care. They were afraid they're going to get COVID at the hospital. Normally my husband works, 60 hours a week and I work, 20 or 30. And he was home making dinner for me while I was late at work. It was a real reversal of roles. And he actually even wrote a song about the pandemic in his time at home. He had the beeper on, but there were no calls. Of course, we know there were heart attacks, but nobody called for help. So it was a very interesting time that way. I'll just say just about the Board of Health. The Board of Health is a slow-moving governmental body, and we were not in a position to make all those fast changes that really had to happen. And so what we did early on, it became clear, one, that I couldn't manage it because I was working at Cooley so much. And two is that as a governmental body that has to post meetings 2 days ahead and have an agenda, all that kind of stuff, we really couldn't be nimble enough to really do what needed to be done. So we actually gave our power to Meredith O'Leary, the director, and she did a fabulous job. I mean, she helped. I mean, the state put out regulations for all these different businesses when restaurants could be open and closed. You remember the restaurants were closed and it was only later that they could do takeout. I mean, so many things changed. And she gave guidance to our local businesses above and beyond the state guidance. And she did a fabulous job. There's no way the Board of Health could have done that. And so we basically gave her our power. And she's supposed to report to us, and we met periodically to go over it, but there's no way we could have kept up on that. So that's sort of my early pandemic experience. I don't know if anyone wants to ask questions or go on to John. Marian, you're muted.
Thank you. Maybe let's move on to John and then see what his contribution is, and then people will get to ask questions.
Okay. Well, that was really interesting because I think that my experiences in some ways were really similar to Joanne's, and in some ways were really different because of the kind of organizations we were. So I think I should start by giving a little background on Hilltown, since I guess probably some people have experience with it, but many people have not. So their Hilltown Community Health Center was started in the 1960s in somebody's living room in Worthington, at a time when Worthington had mostly dirt roads, and there was a nurse there who was concerned people weren't getting medical care. So in the 1970s, it finally became a regular federally qualified community health center, got some federal money, and then opened the Worthington clinic grew. We opened a clinic in Huntington, which is now our biggest clinic. And then 5.5 years or so ago, we opened a clinic here in Amherst in the Banks Center. And then we also run a school-based clinic at Gateway High School, and recently took over the Manna Clinic for homeless folks at St. John's Church. So we're sort of a different model where it's not a big organization. It's about maybe 8,000 patients altogether, but we're spread out all over the western half of the county. And the goal has really been to provide access to people who didn't have it in other ways, either because of their immigration status, insurance status, whatever, or in the hill towns in Worthington, Huntington, there aren't any other medical providers. So we actually see most of the people in those towns. And we are really a provider of last resort. We see people who have insurance or who don't have insurance, and there's a significant number of people who are immigrants or have what's called health safety net insurance. That's a Massachusetts state plan only. They can really only go to a community health center for medical care. So that's sort of the structure of it. We don't have a lot of, there's about 110 or 120 staff, but there's not a lot of administrators. Most of us are in the clinic all the time. So when the pandemic began, there were a few of us kind of paying attention to the news, and by late 2019, we were starting to get a little concerned. January, February, it was pretty clear that things were really spinning out of control. There were cases in Europe and in Turkey, and then we had our first cases in this country of people traveling. And then all of a sudden, as Joanne said, there was community spread. And I think we were not surprised. We had also prepared for Ebola. We had, were familiar with SARS and MERS, and we knew there were going to be respiratory infections like this. But it was clear that this was going to happen, and then it was happening. And the response initially, personally, I found sort of terrifying that CDC was kind of pushed aside a little bit. Homeland Security handled some of the initial response. Planes from China were diverted to military bases where the people got off the planes and mixed with everybody on the base who then went home. It was, from an infection control standpoint, it was terrible. So I think it was the first weekend, maybe the second weekend in March, it was really clear that things were spinning out of control. And I think we had the experience that probably people all over the country had, where on a Sunday morning, I went and met with our senior management. We had this really intense, difficult meeting for about an hour, a lot of tears. And we thought, okay, we have to shut things down. And we didn't really know how we were going to survive that financially or where things were going to go. But it was pretty clear if we didn't do that, it was going to be a disaster. And a few days later, the Department of Public Health required us to do that anyway. So we weren't geniuses. We were just kind of like in the same boat as everybody else. So we had this meeting. We were we knew things were going to get bad, and we pretty quickly over the first several weeks put together a lot of things. And then we it's like Joanne explained, it was so intense. I can't remember all the detail. But the first issue was to reduce the number of people coming in. So we were used to having sort of packed waiting rooms and the clinicians and staff working kind of shoulder to shoulder, and that clearly wasn't going to happen. So we shut down most of the medical clinics. We restricted it only people who really desperately needed to be seen. All the preventive stuff and all the sort of routine stuff got delayed. We were running dental clinics, which are not really separate. They're on the same hallways. So we were volatilizing all this stuff into the air, doing dental procedures. So that shut down immediately. The school-based health clinic at Gateway is not, it opens up off the main hallway by the lobby of the high school. So that was clearly had to go because we had people coming in from the outside into a school, and we closed that down, although the school closed down shortly after that anyway. The eye care services, we closed that down except for emergencies. Behavioral health, which we have a large counseling program that closed immediately. And then over really only a few weeks, we started to shift to telemedicine. Before the reimbursement system kind of caught up to it, before we had any Zoom technology and that kind of stuff, we just started doing telephone visits with people. So behavioral health came back almost immediately within a few weeks, doing everything on the telephone. And we shifted to having more medical visits and eventually even some dental visits on Zoom and on telephone to try and limit the number of people coming into the building. The telemedicine is sort of interesting. It's here to stay, I think, because we kind of over time figured out how to do that. Sort of see people sometimes in the office and sometimes to follow up on the phone. We have never been very good at doing it on video. The idea is everybody has Zoom, but in practice, about 90% of our patients can't handle a video visit because they don't have good connections or they don't have adequate time on their cell phone. So it's almost all telephone, and some of that gets reimbursed at a reasonable rate, and some of it really doesn't. We put into place pretty quickly a lot of infection control measures that we'd had. We always had people wear masks when they came in with a cold and that kind of thing, but we started screening patients for symptoms of COVID and trying to screen out who should come in, who should be dealt with over the phone. We had real serious air quality issues that we never understood, we never had thought about before, but every one of our spaces has different filtration systems. We're in the Bang Center here, we're in a public building which shares space air with flow with the rest of the building. So we actually got an engineer recommended by Cooley to come and work with us and figure out how to redo that. And we put in HEPA filters and figured out if we had somebody in the room with COVID, how long we had to let the room sit with run the HEPA filter with nobody going in before we'd wipe down the room. We had no experience with that, so we learned quickly. We did have a lot of PPE issues. We were never able to get enough N95 masks for the first year, so we came up with the other community health centers with some protocols to reuse them. We use it per day and then put it in a paper bag for a week, and the 8th day we could take it out again and reuse it and do that 5 times. But we made all that stuff up along with a lot of other people. I don't know if there's any good science on that. We were really worried about immunizing kids in particular and not falling behind on that. So we started doing immunizations in the parking lots. In the Bank Center, we couldn't do that, and we actually lost probably most of our pediatric patients in that period. Will they come back? We tried to set up clinics where we'd separate the sick people from the healthy people. So in Huntington, we have physical space where you can really divide it. We had a sick wing and a healthy wing, essentially. And in Worthington, we had people coming in through separate entrances. We still do that somewhat. In Amherst, we only have 4 exam rooms here. So we couldn't do that. We just are careful about not having people pile up in the waiting room. We had a lot of discussion with the other health centers around the state about what are the protocols for how do we manage people with suspected COVID. And Joanne and I talked and emailed a whole lot then, and we did the same with Bay State, which has, we have clinics in different places, and people use different hospitals. But it took us a while to figure out how to manage people who had suspected COVID, when they would come to see us, when they would go into the emergency room, when they would go to the respiratory clinic at Cooley or at one of the Bay State sites. We had real issues with doing that. We had patients in the Hilltowns who go to Berkshire Medical, which was a little less set up to do that. We had major issues around testing. You know, the story is, well, you would go to one of the drive-through test sites, but we had a lot of patients with no cars, and we were not going to put them in a city bus to go across from Amherst to Northampton to go get tested. So we tried to get test kits delivered to their houses, and that there was a lot of price gouging, about 100 different companies selling test kits, and they were not playing nicely with us. So that took months and months to figure out. We got tons of test kits, and we distribute test kits to all of our patients so they can test at home. And the other piece is that the labs were not, well, we had a lab in the Amherst site, which was closed by Bay State because they weren't doing enough business. And we did manage to keep the other labs open, but we were not allowed to do testing through Bay State for quite a while. So that took really almost a year to figure out how to test people promptly. When vaccinations began in 2020, we were kind of totally happy to be involved in that and totally stunned. I have to say my first reaction as medical director is that we should not be doing this. Somebody needs to mute. There's a lot of background. We were asked to vaccinate, thousands of people, not only do our patients, but do community vaccinations. And we had no extra staff to do that. So we redeployed staff. We shut down medical clinics in order to do vaccinations. And we did vaccination clinics in Huntington and Worthington. We still do them in Huntington. In Amherst, because of the issues, like I would love to say that we have single dose vials of vaccine, but we don't. And opening a vaccine vial to do one person and throw out 10 doses was not something we could do. So we've been collaborating with the health department in Amherst, which is, I think, under subcontract with Northampton. And that actually has worked pretty well because people have worked really well together. I am not sure what Joanne's experience was at the hospital, but we had major personnel shortages. So we went from having a couple people out a day to having between 20 and 25 people out every day, either because they had COVID, they were exposed to COVID, or more because they had young kids who were not in school. And we have continued to struggle with that. But the staffing shortages were such that, particularly we were short on particularly at reception. There'd be some White House announcement about we're going to start doing whatever, and 200 people would call the phones, and it would take us 2 days to get through the phone messages. So that calmed down over time, but that didn't really calm down until people got vaccinated and the numbers of cases started to taper off. It was interesting listening to Joanne talk about the communications or coordination with the hospital system. We're independent. We're a small place, like sort of the same scale as a large private practice. There was a lot of work to do the internal communications with staff in each of the sites, communicating with Cooley, with Bay State, with Berkshire Medical, with Holyoke Hospital, because our patients go to all of those places. We had a regular twice weekly call with the other community health centers around the state. We had a twice weekly call with DPH, Department of Public Health, just trying to figure out what the protocols were and how we were supposed to manage that. And I have to say that I think people really, really rose to the occasion. It was amazing how people kind of took charge and worked together. But it really is, in the back of my mind, I keep thinking, people responded because they needed to, but not because we have any structure in place to deal with an epidemic that no one really knew. Should we be listening? We would get conflicting directives from CDC and from the state health department, and we would sit down and kind of figure out, well, what do we think we should do? And then we would talk to the other medical directors around the state, figure out what they were doing. But it wasn't like there was sort of a central command for any community health center. And I still fear that we're in the same place for future pandemics. We just had our first case of monkeypox, and we knew that was going to come. We knew we were going to be seeing that. But when it finally came, getting that person hospitalized was, about 6 phone calls and a lot of coordination trying to get the ambulance company to pick the guy up and get him through the emergency room and the infectious disease. Everybody wanted to talk to everybody, but we should have had those conversations long before. We had a lot of financial issues. We took, I'm guessing, or initially we took about a 40 or 50% cut in revenue overnight. We blew through all of our cash, and that got better as we did telemedicine, got some grant funding from the COVID relief funds. But a lot of medical practices around the country did fail, and we're still seeing patients coming in who are in private practices that fail, and they're finally, sort of seeking medical care again and coming to us because they can't go where they used to go. So that's sort of our experience. It was totally overwhelming. We did work like around the clock for months and months. I think Joanne's statement, it's really so true that other people are saying, "Oh, I'm so bored. I'm at home with nothing to do." It's like, wow, I have way too much to do. And I, personally, my mom's on this thing as well. She can attest. Our kids wound up moving back in, and I was running a lot of meetings from the room I was sharing with my son, where he was sleeping in the room while we were having these 7:30 meetings. I think the lessons are sort of clear. We did really well. We had no transmission of COVID within our clinics. We did lose patients, but we did better, certainly in the eastern part of the state, just by luck, I think. But I think the fear is that we didn't really respond by setting up a public health system that can continue to respond to these things. We're still going to be improvising. So I think I'll stop there. And any questions?
Yeah. So any questions? Carol, you're on mute now. Do you want to unmute yourself?
Yes, I did. It's wonderful hearing from each of you from what you were managing. I feel that's almost been a missing piece in the public awareness. We knew staffs were overworked and suffering and over, but there's a lot of very helpful information for me as a patient to give me more empathy for and to understand what the staffs were going through. John, I'm Carol Beauvais. I worked at Worthington Health Center. I'm a psychologist for 8 years. So I know that system. We actually went out and found the plot for the Huntington Center years ago. But but one of the things I'm just curious about, when the two of you, John and Joanne, hear each other, I don't hear, Joanne, that the hospital had the staffing problems that the health center had, or just because you had so much to administrate that you didn't have time to talk about that. And you had to talk about your piece, which was the administrative response, and that you have a lot, it sounds like you have had more feelings of success at that level. I don't know if I know you have good feeling from the staff, but is it a clear question?
Yeah, so I think we did have similar staffing issues. People had to be home with kids who were out of school, and I think staffing was difficult. But if you remember at that time, many people were not seeking care, and only the people who absolutely had to go to the hospital would go to the hospital. So actually what happened is that, I mean, we're talking about the early COVID, like March, April, May. The volume in the hospital was actually quite low.
Yes.
People who were there were only the people who had to be there, who either had COVID or had to be there. And so, I mean, I'm not really involved in the finances at the hospital very much, but I know they really took a hit, and all hospitals did, because they didn't have the volume. And elective surgeries were canceled, all the money makers were canceled. And
Yes.
so yeah, so staffing was an issue, particularly with people with kids at home. But if you look at the curves, the epidemiologic curves of cases, and you look at that bump that happened in April of 2020, it is
Yes.
much lower than the December, January bumps we had both in 2021 and 21-22. The number of cases with Omicron, the number of community cases is like, I don't know, 10 times higher. It's like way higher. Like, you have a little bump in March and April, and then you have this huge
Wow.
bump with Omicron. And that actually caused a really significant staffing problem that we're still living with. We had a
Wow.
healthcare worker shortage before COVID.
Yeah.
But then, people who work in the hospital are also community members. So when the community rates go up, this is actually a particular interest of mine, is that when community rates go up, the hospital has staffing problems, not because we have so many COVID patients. I don't know if you're tuned in, you are to the CDC graphs, but the CDC has a graph said, it's only a problem if you have, greater than 10% COVID patients or whatever. They have this whole thing, this green, yellow, red system based on how many COVID patients you have. That's not our problem.
Wow.
The number of COVID patients is not the problem. The number of staff out is the problem, and that's not in those statistics anyway.
Wow, that was not made clear. I hadn't known that clearly. Thank you. Yeah.
I mean, and that's an ongoing problem. There's still plenty of COVID out there.
Wow.
I see all the employees who are out with COVID. I mean, it's just constant.
I know. Yeah.
Yeah, I would say we've done better over time in managing spikes of patients, but we have had, we had a third of the medical providers out for a week at a time with COVID recently.
Wow.
Yeah.
So we're still, I think we're all going to be dealing with that for a long time.
And it's interesting I was just going to say that there may have been some cases of transmission within the hospitals. Like some people swore they were careful at home and, took care of a COVID patient and then they got COVID. Most of it is community transmission. People do what they want to do when they're home. They go to restaurants, they visit their sister, like whatever it is. Most of the transmission and cases that we've checked has been community transmission, not hospital transmission.
Yeah, I think the other interesting thing about staffing has been that it's gotten better now, but it was really, really difficult to recruit staff. That we lost some staff, we would offer people a position, they would at the last minute decide, no, I'm too freaked out to change jobs. And then we've always hired new graduates, new doctors and nurse practitioners. And that can be really difficult because people are doing telemedicine and it's hard to supervise people. And that experience we always had of people working really closely together, we couldn't physically be in that kind of space. And it made it much more difficult for about 2 years. We're better now, we've hired people, it's okay, but it was really a problem.
Yeah, it has been a really rough time and continues to be. As a patient, I find what I would call you said things that were really interesting to me around things changing. So the information, who could keep up with the information? Give me a break, and then the CDC and that in itself.
Right. So, yeah.
Yeah, you said so many things. I give other people a chance, but I'm very inspired by hearing what you've had to say. Yeah.
So, anyone else want to ask a question or make a comment? Yes, no.
Click Sarah.
Mhm.
Neither of you really talked, except maybe John very briefly, about the really serious people who were seriously ill with COVID. And I have absolutely no memory of how many people in our area died. That's part of my amnesia. So I wonder if you could talk a little bit about that. What kind of changes did you have to make to receive these people who were suddenly very ill with something brand new? And what kinds of successes did you have and failures?
Yeah, if you remember, I just remember seeing on the news the pictures from Italy with patients lining the hallways, doctors exhausted, providers dying, and hospitals being absolutely overwhelmed. And we were just not knowing what was coming our way. And I know that there were a lot of plans. We were very lucky that sort of the wave came to us just a little bit later than it came to Boston. And that gave us maybe a week or two. And that gave us a big benefit. One is that things shut down. So transmission sort of stopped. And so our wave was not anywhere near as big as we might have expected. But I do remember planning, our ICU usually can accommodate, I think it has 11 beds. And we don't usually have everyone on a ventilator, but potentially, would have 11 people in there who could be on ventilators. They made plans to have 40 people on ventilators. They opened up the adjacent units. They brought the anesthesiologists up from the OR because no routine surgery wasn't happening. So they brought anesthesiologists up for several months up to the ICU to assist in running ventilators. They ended up not using more than their usual number of beds, maybe 11. But it's possible that maybe we had all of those rooms running ventilators at that time. And I have to say that our ICU team and anesthesiologist teams were just unbelievable. I mean, I can't say that they were fearless. We all had a lot of fear because we were both worried about our own health.
Yeah.
In addition to working a lot and managing all these patients coming in. But we know that that's our job. And so we had amazing ICU docs taking care of these patients and doing a fabulous job. Occasionally we would transfer people out, but we took care of most people at Cooley. I can't remember the number of deaths, but it's something I can look up if somebody wants to know. But certainly plenty of deaths and people of all ages. We don't have pediatrics, but it wasn't only the elders. And it was really hard for that ICU staff who saw most of these people dying. It was really hard, but I think everyone was sort of charged up knowing that this was their calling to do this work. And yet it was extremely hard.
I think our experience is sort of the flip side of that, where the really sick patients we were sending into the hospital, and we did have a number of deaths, but it tended to be older, sicker patients, or the last large number where people refused to get vaccinated. But we were overwhelmed with the patients we were managing on the outside, ones who were not quite so sick that we were worried about. And we actually we created two teams, like a nursing triage team to handle all the COVID calls, and a clinical team to help manage those patients because they needed to be checked in on. And we were overwhelming our primary care providers too. So we essentially pulled people out of primary care to just manage COVID. We still had that.
It was interesting that in the hospital, we had treatments to give. Not in the very beginning, but pretty soon thereafter. We had treatments we could give. We could feel like we were doing something. I feel bad for the outpatient providers. There was no treatment, and I'm sure they're getting inundated with calls, and they just had to say, stay home unless you're short of breath, then you go to the hospital. I mean, there's really no, and there's still, no treatment. I mean, there is treatment now. Take that back. There is very excellent treatment now for outpatients, but that's really, really new. So for 2 years, there was nothing, and primary care docs would just get overwhelmed with calls.
Yeah, I would say one of the bigger challenges for our clinicians has been trying to figure out, is it COVID or is it something else? You know, we have a lot of patients with chronic lung disease and other issues going on, and trying to figure out what is going on. It's still an issue. Those are the people we bring in and we see pretty frequently.
Right.
We're trying not to send them to the emergency room.
And you know, so in 2020, that spring of 2020, volume was extremely low. Every other services were pretty much shut down. And then after vaccination happened, I'm just trying to think back, and maybe last June or so, there had been a little moratorium on elective surgeries for a little while because volume had started to pick up. People started coming back, but we didn't have the staff and overwhelmed with both COVID patients and routine care. And that's still a problem. Hospitals are now running really full, not necessarily overwhelmed, but definitely full and fuller than they're used to being. And that combined with staff shortages when staff are out with COVID, everyone's just so exhausted.
Yeah.
We're still feeling those effects of people and delayed care, people who didn't get care those first 2 years, now coming back for care, and maybe things are worse than they were, and for some reason, things are so complicated now for people and medically. But I think also, personally, I think we're all traumatized, and I think that contributes to illness as well. And so there's just so much going on still.
Right. So I think Devin wanted to offer a comment.
It's really a short story. Right when the pandemic broke out, I was working with the Survival Center, and I called Joanne because if I could have gotten a family member of one of our staff tested, then I would probably have been able to work with the staff remaining, and we could have kept the Survival Center open. And so it was a very tense and upsetting time, and we did have to close the Survival Center for just a short period of time. But she's telling you the crisis she was in, and she would still take a neighbor's call and couldn't fix it, but it was so empathetic. And so I just wanted to tell you that kind of backstory was going on. Thank you, Joanne.
Oh, you're so welcome. I do what I can. I pulled whatever strings I could pull, whatever I could.
So I have a question. Both of you have commented on the enormous financial hit that your respective institutions took at the beginning when all the patients, except for the COVID patients, disappeared. Has there, certainly businesses have been compensated by the American Rescue Act, et cetera. Were you ultimately, did the federal government start to kick in money to compensate for the hits you were taking as time went on?
I don't know the answer to that. I'm not involved in that end of things. I know that we're still in a deficit. I know there's still a crunch, but I don't know the details of what kind of help we've had. I'm sure we've had some, but probably not as much as we would like.
Yeah, we did get COVID relief money, and the biggest issue is also we got an increased Medicaid rate, which we hadn't gotten for years and years and years. And that's, I would assume that I'm not the finance director, but I would assume we're probably still running an operating deficit, and we have enough cash and to keep going. But that is sort of the nature of community health centers in general. We're usually, close to a deficit or just break even when we have some federal grant money that keeps it going. We're certainly, the productivity is back up because we have a full staff again, and we're seeing patients.
Yeah. Anybody else? Sarah.
Yeah, so I'm wondering, this is maybe above your pay grade, but does this did the US do worse than countries that have a national health system where the money is, where you don't have to worry about who's paying the bills?
Yeah, I think we had a higher mortality rate than other countries, but I don't know if it's because of the health service or because of our social situation where there are people who refuse to wear masks or refuse to get vaccinated. I'm not really sure.
Yeah, I would agree that we, I mean, at the extremes, you have, America with 1 million deaths, and China with a much bigger population, who had what, about 9,000 something. I don't know it has to do that much with the financing of the system, but the lack of an effective public health system and, the politicization of masks and vaccinations is certainly a public health disaster. People
Yeah,
don't really want government to do those things in this country.
the lack of public, public health has been defunded over, the last many decades. And so in Northampton, we had, I think, one half-time public health nurse to start. And, in the beginning, we were trying to contact trace every single person and put people who are exposed in quarantine and, in isolation. And it was just unbelievable how much public health infrastructure was not there. And I have to hand it to Meredith for really making things happen. I mean, hiring people. I mean, she got COVID money, but also she took on the work. Meredith O'Leary is now the commissioner, what's now called, she's the commissioner of the Department of Health and Human Services in Northampton, took on contact tracing for a lot of the local communities. And Northampton has a basically functional public health division where we have paid staff, but there are many, many smaller communities around. There are like 375 departments of health in Massachusetts that have never really gotten together. There are a few that have coalitions, but a lot of these smaller towns have no paid staff, and they've got like 2 people who will just inspect septic systems, and that's their Department of Health. And that's for a lot of communities in Hampshire County. And so Meredith was great in that they would give her whatever COVID money they had, and she would arrange the contact tracing. And eventually the state kicked in some contact tracing, and Meredith never felt that it was up to par and would continue contact tracing sort of locally as much as she could. But she really did an amazing job of really helping out all the other communities as much as she could.
And that actually,
she had to put it together herself. Yeah.
and that took actually a big load off of us, because initially we got phone calls from all the towns that we served saying, "What are you going to do to protect us from COVID?" And we were kind of up to our eyeballs in our own work. And as the Northampton Health Department took on that role for a lot of other towns, it really helped a lot.
Wow. Anyone else? Well, I have another question. Oh, no, Carol, do you want to? Oh, whoops. Unmute yourself.
How wonderful it is to hear Joanne and John speak. It's just terrific. I can't say enough, but 2 points quick. One was, as a patient, how difficult it was for me. I had several conditions which I was working on, and then COVID hit and disrupted the whole system. And in the end, I experienced unbearable pain for many months. So pain management became an issue for a lot of us outpatient clinics, people who had pre-existing conditions and then couldn't get treatment or had to get treatment. So I just want to bring it up. I had to turn to marijuana and also black market oxycodone. it was unbearable and I had PTSD from it. But I'm happy to be here. The work you guys have done and the work around COVID has been unbelievable, unbelievable. The other thing I want to say is that COVID brought up a lot of, Joanne, you were talking about this, a lot of problems we have about coordination. We're not really prepared, our communication systems. So for me, while I was in so much pain, while I had knee replacement, while I had sciatica, I had to coordinate this system myself as a patient. And I feel, it's too big, I'm old now. But I feel if I were younger, I'd say I would love to address the problem of helping people like myself when they're ill to coordinate their treatment in this broken system. And that's a whole talk. So I just wanted to share, it's wonderful to have the two of you who are doing so much and did so much to hear what I had to say. Thank you.
So Carol, let me just sort of abstract that a little bit about, in this country, about 4 or 5% of medical dollars go to primary care, 4 or 5%. And the big push is to maybe get that up to 7 or 8%. But what you're describing, a hard time managing pain medications, is really the same issues that people have with managing diabetes and all kinds of other stuff, where they need a little more time, a little more care to keep them going, keep them going, keep them out of the hospital. And the primary care system is too overworked to do that well.
Yeah.
Yeah, I'm sorry for your difficulties. I want to say pain management, I think, I'm not a primary care doc, but is one of the things that we have a hard time doing well. There are not a lot of pain specialists around or available. And the other thing you talk about is coordination of care. That's a huge problem with COVID or no COVID. And that's a huge problem. If you happen to have a doctor that's in a different system from your other doctors, like they don't talk to each other. It's just terrible. And that's one thing, single payer system or, national healthcare would solve. And that's a huge thing.
Thank you. Thank you, both of you. Yeah.
Anyone else? No.
I have a question.
Yeah.
At the beginning of the pandemic, there was a coverage of a government report that Obama's administration prepared to be pandemic ready. Is any of that coming back around? Do you see any evidence that we learned that lesson?
I don't know.
I don't mean for you to speak for the government, but I just would love for some hint that somebody's thinking about stockpiling PPE and doing the kind of things that we wished we had done then.
Yeah, he had a whole plan ready and, Trump, threw it away.
Yeah.
I know that there's a lot of leaders in the field that have written a document, I'm blanking on what it's called, about how to move from here. I'll remember what it's called. I'll send it to you. So I think we've learned a lot through the pandemic. The Obama's plan was before the pandemic. So there are people looking at, how we did, what we could do better, and where we need to go from here. So I would try to send that to you.
Over the years, I had such respect for the CDC, so it really pained me that they didn't fare well during the publicity of this story.
Yeah, I've always relied on the CDC, and I think now hopefully they're coming back to be more reliable, but they have some work to do.
Yeah.
Right. Yeah.
Well, thank you both.
Yeah.
Thank you all for listening.
Yeah.
Great, thanks. Great.
So yeah.
Yeah, seriously, thank you for what you do. Wow.
Yes. Yeah. So
Yeah, and thank you, Marianne and Sarah and Nina.
yeah. No. It's so interesting and instructive.
And I hope we do not have another one of these here talking about monkeypox.
Oh,
My favorite subject.
Yeah.
Nice to see you all.
Okay,
Yeah.
thank you.
Terrific.
And nice to see you.
Great, thank you.
Bye-bye.
Bye-bye.